Hello, and thank you for having me at the American College of Physicians poster presentation. My name is Dr. Neil Umles. My colleagues are Dr. Nikhil Gandhi and Dr. Safa Maki. We are from Ascension St. John Hospital in Detroit, Michigan. I'll be presenting a case of calciphylaxis causing systemic emboli mimicking vasculitis. To introduce this topic, calciphylaxis, or calcific uremic arteriolopathy, is a microvessel occlusion disorder that presents as painful ulcerations and necrotic lesions that can be seen in more advanced cases. This has mostly been identified in end-stage renal disease patients, up to 4% of the patients that develop this. It also has a predisposition for peritoneal dialysis, mostly. This is much less commonly seen in chronic kidney disease, but there has been increasing awareness in recent years. It's very important for internists to recognize this in the differential because of a dismal prognosis. Our patient is a 72-year-old female with a past medical history of chronic kidney disease, stage 4, and uncontrolled diabetes. Her chief complaint was bilateral painful distal ulcerations of the upper and lower extremities and necrotic appearing lesions on bilateral shins. On further history, she had ischemic optic neuritis a few weeks ago, and physical exam revealed splinter hemorrhages, as you can see in figure 1. You can also see the painful distal ulcerations. We first ruled out endocarditis with a transesophageal echocardiogram and blood cultures. We launched an extensive workup that, as you can see in the laboratory findings, for vasculitis. The transesophageal echocardiogram and blood cultures were negative, and essentially the vasculitis workup also came back negative. During the time of her initial hospitalization, we obtained a skin biopsy, which was pending throughout the stay. We started systemic steroids empirically for vasculitis. And throughout the stay, we got radiologic workup when we incidentally found severe calcifications when the arteries on retroperitoneal ultrasound, lower extremity arterial duplex, and x-rays of the hand, as you can see in figure 2. At this point, we had calciphylaxis on our differential. On further history, we also saw that her PTH and phosphorus were elevated in the past, and this was worsening on this stay. So we diagnosed secondary hyperparathyroidism in setting of her CKD. The patient's pain and symptoms did mildly improve on steroids, so she was discharged pending her skin biopsy with a possible diagnosis of vasculitis and ruling out calciphylaxis pending the biopsy. Patient did follow up with her primary care physician. The biopsy showed multifocal calcifications without evidence of vasculitis, and steroids at this time were stopped. She did have follow-up scheduled with her nephrologist. However, unfortunately, 1 month after her initial presentation, she came back in frank renal failure and concern for ulcerative infection. She was started on dialysis with sodium thiosulfate therapy, but unfortunately, due to severe pain, she decided on comfort care and passed away the following night, 1 month after her initial diagnosis. Now, to discuss calciphylaxis, this is a very important topic for the internist to recognize due to a poor immediate prognosis and possible presentation in non-end-stage renal disease patients. Pathogenesis is unclear. However, the microvascular calcification is proposed to be a mechanism of cell-mediated process that depends on the promoters and inhibitors of calcification. The incidence is highest among Caucasian women with a mean age between 50 to 70 years old with several risk factors, as can be seen in figure 4. In this case, our patient had non-uremic chronic kidney disease, female gender, age, diabetes, and parathyroid abnormalities predisposing her to calciphylaxis. The prognosis is extremely poor, sometimes 50 to 80% mortality within 6 months. The cutaneous wounds also worsen the mortality due to possibility of sepsis in an unhealing wound. The treatment of this disorder is to decrease the intake and completely take away the intake of any exogenous calcium and vitamin D. Also, avoid steroids and control diabetes well, and treat any other underlying disorder. Patients may benefit from maggot therapy, and parathyroidectomy is controversial. There really is no approved therapy, but the mainstay of what we have been doing is sodium thiosulfate and bisphosphonates or hyperbaric oxygen, and they are under evolving investigation. I highly recommend to involve palliative care early in the disease course. This has been a very educational case for me. I appreciate your time. Thank you very much for having me.